Sure. Okay, so my name is Alicia, and I'm from the PubHlth Association at UCI, and I just wanted to quickly let you know that we do have meetings this quarter every other Wednesday, rather even weeks Wednesdays, from 5:30 to 6:30, and I realize that this quarter this class is scheduled right during our meetings, but our meeting times are the same every single quarter, so please do come out next quarter. And I do have flyers for whoever are interested, so I will be passing that around. And we do a lot of volunteer work, and we do have a lot of guest speakers, so please do come out whenever you do have the time. Thank you.
Hi, everyone. It is my honor to introduce tonight's speaker, Dr. Marc Ofstein. Dr. Ofstein is a fellow anteater. He did his residency here at UCI, and now he serves as the staff physician, the associate chief of staff, and since 1999 has been a clinical professor, all at the VA of Long Beach. Tonight, his discussion will be on veterans' health and also how to prepare us to care better for the growing veteran population. So please join me in welcoming him back to Diversity of Medicine.
Thank you very much, Vivian. And there's a little bit of a, I don't know, can you all hear me if I just talk over here? Hear me okay? First of all, I'm very, very honored to be invited to speak to you. I know this is a course about diversity in healthcare, and you look at a lot of different populations and contingencies that it's important to learn about when we try to understand healthcare. I understand you're a diverse group of folks yourself in a number of different ways, one of those being different kinds of health professions. I know there's a few medical students here, there's some folks in School of Public Health, I think some nursing students, and Vivian, what else am I forgetting? Other health professions? Pharmaceutical sciences?
Just different majors there.
Okay, we're all partners in healthcare, and I'll tell you, in modern healthcare, team is what makes it happen. So I'm glad that there's broad participation here. And I'm very honored that you felt moved to include veterans as a group of folks that are worth hearing about as a special population that gets healthcare in America. And I'm here to tell you a couple of things. I did this for the first time last year, and Vivian was kind enough to give me a lot of feedback. And I think most people liked my presentation where I just described what the VA healthcare system is. And got a lot of insights from that. But one of the feedback elements I got is that folks wanted to hear a lot more about the what the veterans are like, particularly the veteran patient population that we see. So the way I'm going to do that is first I'm going to present off of a PowerPoint some things about who veterans are, the different groups of veterans, and then I'm going to go into some detail about the VA healthcare system, which I think is an important healthcare system. As we all are facing the future of the Affordable Care Act and changes that are happening in healthcare, VA is often cited as a model of one type of delivery of healthcare, and certainly we're hopeful that we'll be able to compete in the new world for our veterans. And I think you may find some other non-VA healthcare systems may look at some of the systems that VA has developed and may adopt them. VA is probably one of the most successful collaborations and partnerships in the history of American medicine has been the affiliation of VA hospitals with medical schools, the nation's medical schools. And there's about 170 or so VAs, and the majority of them are academically affiliated. That means that they have an agreement with a medical school that is somewhat geographically near, sometimes not so near. In our case, just down the 22 freeway. And that has helped both sides of that partnership. Medical schools have gained access to the population of veterans to be part of the learning experience and the clinical range of clinical experience that trainees have an opportunity to learn from. And VA is elevated by the academic flavor that partnership with medical schools make. And that enables us to attract high-quality providers, high-quality not only patient care-oriented folks, but researchers as well. And I think a lot of very high-end research has come out of that collaboration. VA has a very comprehensive, they call it Cooperative Studies program. And one thing about VA, it's very big. And so VA has been able to leverage its size to enroll large numbers of patients in clinical trials that help us understand a lot of things that we now know about medicine. Much of the knowledge we now have about management of hypertension, for instance, which is probably one of the top public health issues that leads to cardiovascular disease, stroke, heart attacks, etc. Much of what we know comes out of VA research. And it's really because of that partnership that we've been able to do it. So first I'll tell you about the VA system and what that's like, and some things about demographic facts about what veterans are like, both veterans who come and see us at the VA and veterans in a larger sense. And then after I'm done with the more formal presentation, what I'll do is I have a lot of experience I do now mostly hospital work. I do ward attending on the inpatient services, but for probably 25 years I did primary care in the VA system at Long Beach, and I have lots of anecdotes of individual veterans, and I will, without revealing their names, I will tell you some stories about what some of these veterans are, so you get a picture of the human side of what our patients are like in VA. Sure, and let's keep it informal. If you have questions, don't shy away from interrupting.
Sorry, what does the A and VA stand for?
I'm sorry, the what?
What does the A stand for? Administration.
Oh, actually, no, it doesn't anymore. Okay, well, this is a very basic talk, I see. Okay. VA originally stood for Veterans Administration. But actually, I forget when it was, maybe the early 1990s, VA was raised to a cabinet level. And it's now called the real official name is DVA, stands for Department of Veterans Affairs. But you know, all the vets called it the VA for 30 years before that, and they did not like any new names, and so we just call it the VA, even though the A stands for something different from what it originally did. And to make it even more confusing, well, let me just launch in and you'll see. So, you can see VA is more than just the health administration. VA is, like I say, it's a cabinet level post. Our secretary is Eric Shinseki, a retired general. He's up here to all the other cabinet members, and I think he's staying on in the second Obama administration. And we're very happy with General Shinseki. He's been a great advocate for VA. So VA has 3 different elements. Actually, the biggest one, money-wise, is called the Veterans Benefits Administration. That is not a medical operation. That is something that attracts a lot of folks to VA. First of all, let me say, I'll bet a lot of folks in this room, or a few folks in this room, are veterans. Perhaps some are actually active duty. And I bet a lot of you have people close to you who are veterans, or else soon will be, or will be. So VA is really part of the countryside of American medicine. So VBA is all about veterans benefits. You may have heard of things called the GI Bill back during World War II. Those are benefits that veterans are accorded after their service. They are often accorded these benefits that help them develop home loans, get education assistance, and other types of financial assistance. One big part of it actually is disability. For those veterans who are injured in the service of their country, the VBA is the arm of the VA that makes an attempt to evaluate what injury they had and provide them compensation. Folks who are very seriously injured may have a pension for life that VA will pay them. And that's all from the VBA department. So that's the biggest part of the VA budget-wise. The biggest part, employment-wise, is VHA, and that stands for Veterans Health Administration. And that's the part I'm going to talk to you about today. It's basically the VA healthcare system. It's a system of hospitals and clinics. I'm thinking about 300,000 employees, something in that range. So that's the VHA. And then finally, we honor our veterans all the way through life and into death. And the Veteran Cemetery Administration is the third component of VA. And as you know, as a department, as a cabinet level department, for those of you that are government buffs, that would put them in the executive branch of the healthcare system. Ultimately, our boss is President Obama. So the scope of the system, 152 hospitals or medical centers. Yeah, that's probably good. 804 community-based outpatient clinics. More and more, we want to get to where the veterans are and build clinics that are closer to them. Here in Southern California, the way it works is each of the major hospitals will operate some of these community-based outpatient clinics. Long Beach operates a clinic in Laguna Hills, another one in Anaheim, another one in Santa Ana, and another one in Whittier, and then a very small one that's more oriented towards recovery and substance abuse that's over in, it's called the Villages at Cabrillo. It's in downtown Long Beach. And each of those clinics is operated either directly by us or we pay a contract to have it operated, and we oversee the care that is provided in the veterans in those clinics. But the point is to try and get access to health care to where the veterans are. The veteran centers are not actually medical operations. Those are more veterans assistance centers. There are some pathways by which folks can access medical assistance through those veteran centers. A lot of it is peer counseling and help, social work help for veterans who may be homeless and have social challenges of that nature. 131 National VA Cemeteries. There's a big one if you ever drive up the 405 freeway past around where UCLA is. You may see off to the right is a large veteran cemetery. I think that one I think is actually all full. And anyone who needs burial privileges in VA cemeteries in Southern California now, I think they're allocated over to Riverside, where there's another larger VA cemetery. and 58 VA benefits regional offices. Again, that serves that VBA, Veterans Benefits side of the system. So who are veterans? Well, one thing about VA, veterans are largely defined by the era of time during which they served. And there's somewhere between 24 and 27 million veterans who have been in our databases since the beginning of VA. And there still are, this data is about a year old, and so I'm afraid the World War II cohort, maybe a little less than 2 million now. Korean conflict era veterans, you can see about 2 million veterans left. The Gulf War conflict around 1990, there's about close to 6 million veterans in that group. There's about 6 million veterans who never really were in service during an era of conflict, that's about 6 million. 7.5 million Vietnam era veterans. Right now, those are the folks that are really in prime time for medical illness. Those are people who are my age, late 50s to late 60s or so. And that's when folks in modern day America get consequences of those diseases I talked about, like hypertension, diabetes, and start to need a lot of intensive healthcare services. And finally, the cohort we talk about a lot these days are our nation's newest, youngest veterans, those who have participated in the current conflicts that are called OEF, Operation Enduring Freedom, Operation Iraqi Freedom, and Operation New Dawn. These are the current veterans who are coming back, and there's about 1.4 million. I think the number there is inching up closer to 2 million now. And so those are the cohorts of veterans, and each of those cohorts of veterans have some things that are characteristic about them.
Can I ask a simple question?
Of course.
To qualify officially as a veteran, so many people go to one war, they remain in the military, and then they go to another war. Do they have to officially be discharged from the military?
Yeah, if you're still active duty, there's a whole separate healthcare system that is part of DoD, Department of Defense. There's a little overlap. We cooperate with them. I'll give you my first anecdote. I just saw this yesterday. What a tragic story. 32-year-old active duty Navy SEAL was on a vacation in November, teaching his niece how fun it was to ride quads, those ATVs. Flipped, rolled over on him. Thank God the niece was completely spared and thrown safe. He is now paraplegic. And I met him yesterday. He's in our spinal cord injury center. So he's an example. He's still in the active duty. So sometimes, and the reason we're caring for him is we have a spinal cord injury center that not all VAs have, and most Department of Defense operations don't have. So he's one that we have an agreement with the Department of Defense that will provide his rehabilitative care because we're good at it and we have those resources. Then other things about access to care. It's a little, so first of all, to be eligible for VA health care, so usually in most situations you are already discharged from the military. So that's number one. Number two, it has to be an honorable discharge. If you have a dishonorable discharge, you may not be eligible for VA care. And that's a very small number of veterans. Now there is also somewhat of a little bit of differentiation depending upon your income and your means. The VA does what's called a means test. When veterans apply for health care, they ask you what your resources are. And folks who have limited resources, I think the number is less than, I think it's $26,000 a year of income and net worth less than $100,000. Those folks have definite entry into VA. They are not charged for their health care. And they have full access to the whole system. Folks who are more fortunate and have higher earning may be still, it's actually discretionary that they may be allowed into VA, and it depends on the capacity of the VA system. There are some VA systems around the country that won't admit folks who have more resources, the theory being that they could afford other types of health care. In Long Beach, and all of Southern California, we do have some of those veterans who are higher than that threshold. But those veterans are charged money for their visits. It tends to be a lot less than they would be charged. Usually for a primary care visit, it's $15. For a specialty care visit, I believe it's $50. For medications, if they're in that group that is charged, they're charged $8 per prescription per month, which if it's aspirin is a bad deal. But if it's one of the advanced modern biologically engineered drugs that is $1,050 a month, it's a pretty good deal. So that's sort of the financial arrangements for.
This may be a good time for me to ask this question, but if you rather wait till.
Go ahead.
Because I haven't read a story about suicide and family members of vets becoming a big problem.
I saw that in the LA Times, yeah.
So are the family members also covered?
No. That brings up two important issues, and I'm at risk for getting a little disorganized in my talk, but if you're interested, I'm good with it. First of all, suicide among the OEF, OIF veterans, the young cohort of veterans, is a huge tragedy and a big concern for us. More veterans are dying of suicide than in military combat right now. So that is an area of extreme concern for us, and we've done a lot of resources into our mental health departments to try and deal with that. I saw that article in the LA Times. It's like it's catching. Obviously, severe depression and suicidality is something that can envelop a family unit, and I think I can understand some of the dynamics there. Generally, no. When they're active duty, I believe they are eligible for care. When they're veterans, they can get, for a relatively lower price than would otherwise be the case if they were just unaffiliated with military, they sometimes can access something called TRICARE. TRICARE is a system where dependents of veterans, so family members, can apply for, it's essentially like insurance for health care and access the system. It's a small number. In our VA at Long Beach, we have about 52,000 veterans come to our hospital for care. I would say about 1,000 folks are these non-veterans of that 52,000. Moving along. Okay, so I just said there's maybe 27, 30 million veterans, but how many of them actually come to VA for health care? Well, it's a subset of veterans who seek care in the VA, and the latest number is around 7 million. And why is that? Well, folks have a lot of choices for health care in modern day America and have other options. A lot of folks who are employed and have access to health insurance through employment, and then I think a lot of other options coming up soon as the Affordable Care Act plays out, will have other choices. So VA very much competes for the interest of veterans, and we feel that we're attuned to the needs of veterans, and we'd like to have more veterans come and see us. And so that's why there's a subset. So the question is, are veterans who come to us for care different from those that aren't? And statistically they are, but individually there are many examples that I can cite you that are not. So what do I mean by that? Well, so here's some things about just comparing veterans at large. So now we're not talking so much about VA patients, but who are the veterans in America? So first of all, despite all these young veterans, the median age of current veterans is still pretty old. They're 64 is the median age. Whereas the median age in general, the general population in males is 49. So veterans are older as a group than the general population. For females, it's a little closer, and I think that probably is logical to you because prior to the last 20 years or so, not very many women went into service, but more and more women are now. And so you see that the median age of female vets is much lower than for male vets. Here's some racial statistics. White non-Hispanic category is 82% of males. So you can see white males are overrepresented in that cohort. Whereas in non-veterans, as everybody knows, and I think was brought home to us in the last election, America has a different demographic from what it did 10 years ago, 20 years ago, 30 years ago. And so you're seeing those, since those veterans, remember those male veterans are a lot older, they're from an older age group, they are not as diverse in their racial background as the general population is. And as you see, non-white, non-Hispanic, about 13% or so, as opposed to almost 20% in non-vets. And the Hispanic group of vets is the smallest group and lagging behind the general population. And we're seeing lots more Hispanic vets in the younger cohorts. For women, again, because of the age difference, you see there's not much difference between veterans and non-veterans in their ethnic breakdown. About equal number there that are white, non-Hispanic. And again, Hispanic vets are lagging behind the general population. I expect those numbers to change in the coming years. Marital status, vets in general, they're a little bit, again, because the male vets who do predominate in the population really define the population of veterans. They're more typical of old school, older demographic, and so therefore they have a higher rate of marriage. They also have a higher rate of divorce. Same for separated as compared with non-veterans. And much less likely to be never married. But again, remember, those non-vets are often much younger. So give them time, and I think those will even out. And again, same kind of pattern for the female vets. There's not that same disparity that you see, again, because the female vets as a cohort are younger. Occupation of veterans. Actually, it's interesting because VA is largely thought of the healthcare system as an indigent healthcare system, a safety net healthcare system, and it's certainly true, and I think it's evident by what I said about eligibility. A lot of veterans who are successful, employed, may not seek their healthcare at the VA, but use the healthcare insurance that they have available to them through their employment. So This is very different from the cohort of veterans who seek care from us. You'll see that actually in general in American culture, veterans tend to be a little bit more successful than non-veterans. I don't know if I have it on a slide here, but a higher percentage of CEOs of Fortune 500 companies are veterans than would be represented in the general population. And so that's a difference between the general population of veterans and those who seek health care in the VA. So in general, most veterans really do very well in life after their service. Sometimes those of us who work in VA, where we often see some of the more challenged and disadvantaged populations, lose sight of that fact. And we tend to think of veterans as disadvantaged, disproportionately homeless, disproportionately burdened with both medical and psychiatric disease. That's not really true of veterans in the nation. As you can see, and again, this probably relates to the fact that the general group of male veterans is older and again, as I just said, often very successful. They will often have mixed both public and private insurance in that it parallels their age and Medicare eligibility. Just some stats about their statistics. Again, these are 30,000-foot stats. I'm not sure how much insight they give us really into individuals, but as you can see, male vets' earning power is slightly higher than male non-vets. Again, they were older too, so that probably plays into it. And female vets, where there isn't that age discrepancy, actually have a little bit of edge in their earning power. So veterans, by and large, in American culture, is a very successful group of folks, and I think that's important to keep in mind. So just, again, sort of an executive summary of statistics on veterans. Most vets are 55 or older. They're generally non-Hispanic. 84% identify as white only. 91% of the current cohort are males, but that is rapidly changing. 75% report owning a home, 70% are married, 70% no longer have dependent children. That goes along again with that older age demographic. And about a third of veterans have actually been exposed to combat, and most of those exposed to combat have been exposed to death. So how are veterans who receive health care in VHA different from the general population of veterans? Well, first of all, there's a higher proportion of non-whites. There's higher level of unemployment, fewer lower level of achievement and success professionally, higher rate of homelessness, and less likely to have private insurance. And so that characterizes those veterans that come to us for care as compared with the general population of veterans. Unique challenges by cohort. I mentioned that a lot of times the actual cohort of veterans to which a veteran belongs does define what their needs are. So really your World War II and Korean era veterans, they're getting pretty old now. Most of those folks are well over 80. And so the challenges of geriatrics are really their healthcare challenges. Vietnam era veterans, as I mentioned before, they're people who are really kind of, I'd like to call it prime of life. They're my age. But they're getting older, and at that age, that's when you start to see the higher cost medical illness. Again, as I mentioned, diabetes, hypertension, obesity, all the things that affect most of America in way too high numbers affect veterans as well. And those things, you know, you can live a long time being overweight, hypertensive, and diabetes, and you can ignore it. But eventually, you know, you're going to pay the price. And when does that happen? Well, for the Vietnam era cohort of veterans, it's happening now. And so what are those things? Well, it's heart attacks, it's heart failure, it's strokes, it's limb loss, it's the other ravages of diabetes, kidney disease. All the things that really run up the cost of healthcare is predominantly in that age group. Gulf era folks are younger than the Vietnam era folks. The leading edge of those folks are starting to get illnesses very similar to the group I just described. The younger cohort, many of them really we focus on preventive medicine. Now for the OEF, OIF, OND folks, we heard the discussion about suicide. And indeed, psychiatric challenges are probably their biggest need. And VA has really been excoriated in Congress for failing to step up and meet that need. About a year ago, Congress did an assessment of access to mental health services, especially for the OEF, OIF, OND veterans, and found it to be wanting. We're measured in a lot of different ways. In a little while I'll talk to you about how we do that. We have a really sophisticated electronic medical record, and one thing about that is it allows us to capture a lot of statistics very quickly and very easily. And what we saw is many veterans seeking treatment for PTSD, post-traumatic stress disorder, which is probably the principal psychiatric challenge that that group of veterans have, and underlies or is definitely associated with the risk of suicide for that group of veterans. We found an inordinate number of folks were waiting more than 30 days for an appointment. That was recognized as a national shame, and VA was very much called on the carpet in Congress. And so about 6-8 months ago, there was a huge initiative called R19, and what that was is VA nationwide hired 1,900 mental health employees to try and close that gap and improve access to care for mental health services. And we had 2 months to do that. I can tell you, VA, possibly in concert with the nation's prison system, has nearly single-handedly driven up the starting salary of a psychiatrist into truly stratospheric levels. New psychiatrists starting out start out at around $230,000 a year, which is much higher than was true about 3 years ago. As opposed to, just to give you an example, a newly starting out hospitalist probably makes somewhere between $170 and $200, depending on where they work. And a lot of that is due to tremendous demand for hiring mental health professionals, particularly psychiatrists, in VA.
You see that they are at a higher rate in veterans than they do in the national rate?
I think by and large, well, you do, certainly PTSD, which was first defined in the veteran group, is a VA concept, actually. You do see that in a higher group. And for folks that are closer to service, you do see that. In the older age groups, probably not. As people get more distance from their service, you see less affliction with those mental illnesses, and they begin to look more like the pattern of mental illness in other adults their same age. Again, I really want to drive home the point. The average veteran is a pretty normal guy or gal who is very much like the general population, and as I mentioned before, in many ways, slightly more successful in life. But that doesn't define the veterans who come to us for care, who tend to be at the other end of that group. So mental illness is number one in the OEF-OIF group of veterans, but also musculoskeletal illness and other kind of miscellaneous so-called ill-defined conditions. Some cultural considerations, and these are my observations. First of all, it is interesting. This week, our hospital is having a visit by the Joint Commission. Joint Commission is a group that comes and accredits all healthcare, and they hold us to the same standards as all other healthcare. And something that's very popular, this goes along with that whole thing about diversity in American population. One thing they look at is, what is the patient's preferred healthcare language? What does the patient want to be communicate? How do they want to have their communication with their provider? And traditionally in VA, it's not been that much of an issue because it's hard to get into service if you don't speak English. So the majority of veterans, English is their preferred language. But I think you're going to see in the younger cohorts, there may start to be some broadening of that and seeing other languages. Probably Spanish will be become very important in VA in the near future. And for those people that are in that TRICARE system, I've personally cared for the elderly mother, a Hispanic woman of a active duty soldier, and she spoke only Spanish, so it can be useful to have Spanish capability. Also, the hospital has actually contracted services for a much broader range of languages, so if we do need to translate, we're able to do that. Another comment about what veterans are like. Veterans are tend to be very grateful for the health care that they get, and it depends on the cohort. I find that to be true across really the spectrum. In my practice, I had veterans that ranged from homeless and very, very challenged to, I probably had a half a dozen folks who were independently wealthy, who had other options in healthcare, but they just liked coming to the VA. Usually those folks would use the VA for certain things and their private insurance for other things, so they would use a mix of healthcare. But almost across the range, you really encounter a lot of gratitude. It's very gratifying to work for VA. Veterans are wonderful people to work for. For some veterans, you know, especially the really the homeless, the downtrodden, some of the folks that are mentally challenged, they don't get a lot of respect elsewhere in the world. They don't get people to listen to them. They're not valued as people. And in VA, they are. It's very gratifying to speak to some of those veterans because they do recognize that. So as you see, I said, remarkable range from homeless to wealthy. I'll toss in actually one of my anecdotes here. One of my patients was a guy, I knew him from the time, I practiced primary care for about 25 years, and I followed this guy for about 20 of those years. So I saw him from his late 50s to his late 70s. And actually he was a cop in the LAPD, but he had done very well with his investments and actually became kind of wealthy in his post-retirement career. But he continued to come to VA. And was, so he was, I would say, 57 when I first met him, 77 when I stopped doing primary care. Generally healthy guy, physically active. He retired to a ranch in Temecula. He had horses and probably would have half a bottle of wine a day with his alcohol consumption. Married, grown kids. And truthfully, he didn't have a whole lot of healthcare challenges. He had arthritis. had mild hypertension that was well controlled, did not have the consequences of that, did not have serious heart disease, lung disease, strokes, was not a smoker, and was basically pretty comfortable, kind of upper middle class American. So there's one example. Veterans tend to respond to collaborative decision making. That means they like to be involved in their health care. They like to be consulted on working together on recognizing what their problems are. I'll tell you, if it comes down to what it really is a doctor and what good are we to patients, you know, we have a lot of, and the same would be true for all of the healthcare professions. We get a lot of technical expertise in our training and our practice. And so what we do is we bring to an encounter with the patient that technical expertise, that training, and then for hopefully at least a moment in time, and sometimes much longer than that, if it's a longitudinal relationship, we look the patient in the eye and we care about them. And what we do is we then, starting with that spark of contact and caring, we then reach back to our training and become analytical and understand what their healthcare situation is and their challenges and their problems. And then, in my mind, the best thing we can do for patients is be a guide to them, explain to them what our understanding of their challenge is, help them achieve equal understanding to what we understand, help them explore the options and make the choices that will improve their health. And veterans like that. They're very collaborative. Some folks respond much more to a paternalistic healthcare environment where they just say, you're the doctor, you tell me what to do. My experience with veterans is they like to be involved in their healthcare and partners in decisions about what to do. And I put down there, they're hostile, and so if you try to get paternalistic to them, sometimes they don't like it. So some things about the VA itself. First of all, I think it's the world's largest single integrated healthcare system. There is, of the cohort, there's some degree of homogeneity of the cohorts. That is, there are a lot of things in common that the Vietnam veterans have. There are a lot of things in common the World War II veterans have. And so that's a distinctive feature of VA. They have been predominantly men. Again, as I said several times, the younger cohorts, we're starting to see many more women. There are these eligibility issues. I think I already talked about this, the service connection, the co-pays, and so forth. We covered that. There's some things about VA. Some people say if you've seen one VA, you've seen one VA. Other people say if you've seen one VA, you've seen them all. And both, as conflicting as those two statements are, there is truth to both of those elements. But most of the VA hospitals do have very similar demographics. I tell you, the one really different VA in the whole nation is the San Diego VA. The median age of the veterans under care at San Diego VA is about 10 years younger than all the other VAs in the nation. And that may be because they're very close to the large military installations that are located in San Diego, and I think they do very aggressive recruitment of young vets coming out of service, so they have a larger number of younger vets. But most of the other VAs have very similar patient population. My first experience in VA healthcare was when I was in medical school at Georgetown. My first clinical experience was at the Washington, D.C. VA. And when I came to Long Beach, I felt right at home. Those veterans were very similar. But we are seeing increasing diversity, as I mentioned. There is substantial homeless enrollment, and trying to do something about that is a big initiative that Secretary Shinseki has put forward. We do deal with a lot of chronic medical disease, but that's not much different from the average middle-aged American. Again, the main chronic diseases are diabetes and hypertension, probably the biggest ones. Degenerative joint disease, those kinds of things. And then the mental illness challenges, again, are particularly prominent in the younger cohort. And the Vietnam era had certainly more than their share of, that was the era that developed the PTSD diagnosis. So how do we try to do healthcare? We have a patient-centered medical home model. What that means is we try to provide primary care with an adequately resourced primary care team. So we use formulas for this. We call them teamlets. Each teamlet has a provider, usually a physician. Most of our physicians are internal medicine trained physicians. We do have some family medicine docs, and they actually do very well. The older cohort of veterans tend to have more serious, complicated multi-system disease that internists are a little bit more comfortable with. So you will see more people trained as internal medicine doctors than as family medicine in VA. But still, I think there's actually plenty of room for family medicine docs in the VA. So there's a doc, there's a nurse who's in a role called case management, there's usually a medical assistant, medical tech type person, and a clerical person. So there's those four people. We have a formula, about 1,200 veterans can be cared for by that group of people longitudinally over time. And that's very similar to the kinds of, you'll see those stats in any kind of modern healthcare organization, how Kaiser operates, or really most of the other organized healthcare systems. We're trying to really orient ourselves much more towards health maintenance and illness prevention. And we're starting to look at life coaching, trying to improve healthier lifestyles, better nutrition, more exercise, trying to curb obesity, the kinds of things that are difficult to do, but can really pay great dividends if you're successful with them. Substance use is a big thing for us. There's a lot of alcohol use in veterans, a certain amount of other illicit drug use in veterans, and we have a lot of resources that are channeled towards programs designed to help those folks. Overweight, not any different from the general population. A scary percentage of veterans, just like a scary percentage of ordinary Americans, are overweight now. Some folks think that that is a much greater risk for the nation's, the integrity of the nation's healthcare than diabetes, which is really saying a lot. Not that the two aren't connected. So although we try to do a patient-centered medical home model, which usually is primary care, a lot of veterans, again, those in the older cohorts, have complicated medical illness, and you can't do that without advanced specialties. And that's where you really get into these, the need for all the different subspecialties of medicine, the surgical specialties, and collaborative work really with all the other health professions in a team model. So we do largely the patient-centered medical home is outpatient care, but when people need it, they need a hospital, and we have a hospital system. Most of the care we do for veterans, we try to do in those VA medical centers. Not always possible. Sometimes demand exceeds our ability to serve those veterans, but VA still honors its obligation to those veterans, and we have a program where we pay for care in private hospitals. That's called fee care, and we have a transfer system that works with private hospitals to share some of that care. There are veterans who get care at UCI Medical Center. So one thing that VA is especially proud of is VA is considered an industry leader in the EMR, electronic medical record. And we've got about 15 years now of experience of having an integrated electronic medical record. And if you've been following the debate about healthcare, you know that everybody looking at the future of healthcare thinks the electronic medical record is an important tool. And for us, it definitely has been. Our experience, I think, really has defined a lot about the benefits and the risks of an electronic health record. And it was a vision of a guy named Ken Kaiser, who actually started his career as an ER doc in California, was here during the Reagan administration in California, when Reagan was governor in California. Question? The risks? There's a couple of risks. One is that sometimes your electronic medical record does not talk. Medicine is very complex now. And a lot of medical equipment, for instance in radiology, other diagnostics, captures information electronically. If your systems don't speak to one another, it's hard to get that information back. And sometimes a written report is more effective. That's one way. Another way is a little bit more sardonic, and that is we think, and I don't know if any of you have had the experience of working in the VA system or other systems with electronic health records. When people see it, it is interesting, especially physicians. Physicians have been very resistant to the use of electronic health records in most places in American medicine. Not the VA. And the reason not the VA is because in the VA, we employ the doctors and we can make them do it. And they don't have a choice. And that's why VA likes to tout how great they were and how good we did with the electronic medical record. Well, that's because we can really force the doctors to do it. I have friends who work at Hoag. Hoag is just now implementing the physician order entry piece. And the physicians are not happy. And they are coming along very slowly. And some of it is just people are resistant to change. Some of it is as simple as that. And it was that way in the VA. Boy, did they complain and whine when we first started the electronic. What do you mean, I have to learn to type? That's ridiculous. Now, you guys are pretty young here, so you're all used to computers and everything. And these days, everyone's very comfortable with it. But, the older cohorts of physicians, they did not like it. And we had to do it like little by little. But still, we were able to make them do it. So what I was going to say is the electronic health record, when you first start to do it, once you get over not wanting to do it, you get to see all the many benefits of it. The main one is organization and legibility, first of all. So every note is legible. And usually if you've seen the VA record, it is just like a chart. There's a GUI interface, a graphical user interface that is very set up to look like a chart. It's got little tabs on the bottom where you have medicines, you have laboratory data, you have notes, all that kind of stuff. And so once you just, you surrender and you're into it, most people love it. And there are some really, really attractive features to it that are very useful for teaching patients. You can, for instance, there's a cover page. They're called pages, but it's all electronic. The cover page gives, the vital signs, including the weight. You can double-click on the weight, and you instantly see a graph. And that's a powerful tool. You turn the screen to the veteran, and you show the graph going like this. That's helpful to say we should do something about this. You can do the same thing with the labs. You can show them their sugars if they're diabetic, or their hemoglobin A1C. That's a test we use for adequacy control of diabetes. You can see trends of their hemoglobin A1C. People love the electronic medical record. What they sometimes don't realize is they think it was a tool designed to make it easier for them to manage patients. And at some level it was. But the truth is, the subversive truth is, the electronic medical record is designed to manage the providers. And what do I mean by that? And that's a little bit of a pitfall of the electronic medical record. What that means is, how do you think we're able to do physician report cards? And more and more, if you work for a healthcare system, I don't care what your stripe of profession is, your performance is tracked. And probably for physicians, it's tracked most closely. So for instance, if I'm a primary care doctor and I have my 1,200 patients in my panel, like I said I would have, and let's say 350 of those are diabetics, which is about average. About a third of Americans enrolled in healthcare systems, VA or not VA, are diabetic these days. The computer knows what % of my patients have hemoglobin A1Cs greater than 9, which is considered poor control. And they also know the guy practicing next door, they know what his number is too. And if my number is 10% and his number is 3%, my boss is going to come talk to me and say, why are you 10% and this guy's 3%? And so at the healthcare system level, if Long Beach VA, that number is 5%, and at San Diego, it's 3%, then our leadership in the hospital will be called on the carpet and said, why are you as a healthcare system not performing as well as the next one up the road? So it's a tool for measuring performance. Now, I'd like to put that in a positive spin, and I think largely it is used that way. The whole point is really to improve healthcare, and that's certainly why everybody that talks about the importance of electronic health record for improvement in healthcare in America, that's how you measure healthcare. And there's a data farm in Austin, Texas. VA has a big contract with Dell Computer, which is based in Austin. They have buildings that are acres in size. There's hardly any people in there. It's all equipment. And that computer center generates these kind of statistics nationwide. And hospitals are compared to hospitals, within the hospital, doctor to doctor. And all of that helps. The idea is to improve the breed. So that's the purpose of this slide. So what are some of this? So I've already been through a lot of this. Just something about the organization of the VHA system. Like I said, there's about 150 or so hospitals, but we're organized into these, they call them VISN, stands for VISN, Veterans Integrated Service Network. It's basically just a geographical grouping of hospitals. There's 21 of those. We're in VISN 22, which seems pretty illogical since there's only 21. But the reason for that is there originally were 22, and VISNs 13 and 14 were kind of too small. When they first developed them, it was a brand new idea when they first, at one time, and I lived through this era, it was like the Wild West. Every VA ran by itself and was very loosely controlled by central office. And furthermore, the budgets used to be, how much did it cost you to provide health care? Okay, here's a check. Those were the good old days. Okay, those days are gone, and the tool of that was organizing the VA into these regional operations. So they started out with 22 of these networks. That guy Kaiser, he was really the visionary of the VA. I forgot to finish that story. He was in California, and then he went to the VA in the late 80s, early 90s, and he was the visionary that saw the importance of the electronic medical record and also the organization of these networks. And so for us, it's Long Beach is somewhat the geographical center, a little bit off to the side. But then there's the big VA up at West LA, the VA down in San Diego, the VA in Loma Linda, and the VA in Las Vegas. That's our little club. That's our network. The reason there's 21 now is VISNs 13 and 14. Once they got operational, they realized they were sort of too small to justify the resources of that regional office, and they had a shotgun wedding. So there's no VISN 13 or 14 anymore. So that's why we're number 22 and there's only 21. And then central office is in Washington, D.C., and they really do try to centralize the communication and kind of set out expectations and standards for the whole system. So one thing we do with that electronic health record is we measure quality. And you heard me talk about the hemoglobin A1Cs. That's one of about 60 clinical performance measures that are looked at for each hospital to see how well we're doing with the care of veterans. Another thing we follow very carefully is availability of appointments. You heard me talk about the crisis in mental health access. Another thing that we struggle with, and most hospitals struggle with this, especially right now, in late January 2013, and pretty much late January every year, flu season tends to bring not so much the flu per se, but respiratory illness, people with a lot of chronic heart and lung disease who get viral respiratory conditions. It's not so much the virus that's the problem. That's what decompensates their other chronic diseases. And there's a lot more demand for patient beds, for hospital beds, in this time of the year. And I can tell you right now, many of the hospitals in Southern California are very impacted, where you cannot find a bed. And that's called inpatient flow. And this is something that most modern hospitals struggle with. Most hospitals, because the cost of healthcare is so high, most hospitals have minimized the number of beds. I think it's something like over $1 million per bed. You know, if you calculate the cost of building a 100-bed hospital, it's $1 million for each incremental bed that you build. And it's not that the bed's not that much, although those beds are getting pretty pricey. They're about 20 grand for a hospital bed these days. But that factors in the cost of the construction and the support to have the infrastructure to have those beds. So most hospitals trying to lower healthcare costs are at the minimum number of beds that they can live with to serve the population that they need. And the truth is, sometimes they're a little bit below the minimum number they need. And that means patients wait in emergency departments because there's no bed for them in the hospital. And VA is no different from any other healthcare system. And there's a whole science of trying to improve that and looking for ways to move patients through continuum of care and get that better access. Inpatient quality measures. To me, this is the most sophisticated use of the electronic health record for tracking performance. There's now they got a building, but originally it was 2 double-wide trailers in the parking lot of the Cincinnati VA. And it's called the Inpatient Evaluation Center, and they're wired to every VA in the nation. So when a nurse takes a blood pressure on South 8, the ward in my hospital, that data is accessible by those trailers, by people in those trailers in Cincinnati. And what they do with that data is they look at every VA hospital across the nation, and they look at what is your mortality rate, what is your hospital length of stay, and then they compare it with the average. For mortality, they adjust it by the degree of severity of illness of the patient population. And those of you that are more sophisticated in healthcare have heard of the Apache score. That's a tool that's used to predict a mortal outcome in seriously ill patients. VA has a similar calculation. So we can see people who have higher mortality. So a hospital can't say, well, my statistics look bad because I'm taking care of sicker patients. The statistics take that into account. And I'm very, very proud to say at Long Beach, our SMR, it's called Standardized Mortality Ratio, is about 0.74 and has been about that level for about 4 years. That means a veteran getting admitted at Long Beach has about a 26% lower chance of having an outcome of death as compared with the average VA in the nation. And we're very proud of that. And our length of stay is just a little bit under the national average. That's called OMILOS. OMILOS stands for Observed Minus Expected Length of Stay. And so if a hospital is performing at the national average, that number would be 0 because the observed and expected are the same. So you want to have a negative OMILOS. You want to have a standardized mortality ratio less than 1.0, and you want to have an OMILOS less than, negative in the negative territory. I can tell you, your hospital will be spoken to by leadership in central office if you're in the wrong quadrant. If you have higher mortality and it's taking you longer to achieve that poor mortality, you're probably got problems in your hospital. If you were a healthcare administrator from another planet and you came and you just wanted, a lot of healthcare is about measurement, and you wanted 2 measures, the simplest possible measures for quality of care and cost of care. Probably 2 pretty good measures, at least for hospital systems. One would be your mortality rate, and the best proxy for cost of care is length of stay, because every day in those very expensive beds adds cost. So if you're in a quadrant with high mortality and long length of stay, there are problems in that hospital. And more and more, you're going to see this. Actually, this is not just VA, this is everywhere. Looking at health-associated morbidities, you may know that Medicare is now saying they're not paying for extra days of care that are due to, say, healthcare-acquired infections. Vivian and I had a little discussion about hand washing in the hospital and how we're not really where we should be. What did you say the number is? 68%. 68% of people who should be washing their hands are washing their hands. And what does that mean? Well, the ones that didn't wash their hands are at risk for transmitting an infection to someone else. Well, Medicare is getting tough about that. And if you're a hospital and somebody gets a nosocomial, that means transmitted in the hospital, infection, and needs 3 extra days of ICU care, first of all, that's astronomically expensive. 3 days in an ICU is probably $35,000 to $50,000. You will not get paid for that. You have to eat it. And so it's very important that's a big incentive for hospitals to work on those kinds of quality improvements. Hospital Compare is actually a published database where average citizens can look up how an individual healthcare system, VA or not, compares with other healthcare systems on these important statistics. Big things that they look at are mortality. Particularly, I think Hospital Compare looks at heart attack, pneumonia, and heart failure. And they look at mortality and I think readmission rates for those. Generally, we compare favorably. We had a higher readmission rate for heart failure a few years ago, but we worked hard to improve that. VA's developed a lot of tools. These are software tools that VA uses to try and manage that patient flow. I won't go into any detail with those. And then, again, we have all these different dashboards. And at the root of them is the electronic medical record as a tool to capture all this information that's used to give feedback to those of us who are providers and to those of us who are administrators about how well we're doing. Interesting thing about cost. VHA budget is around $50 billion a year, 6.4 million active users. If you just take the 30,000-foot approach, that's $7,800 a patient. Is that a lot? I don't know the answer to that question. One thing about VA, though, is to be in that database, you are a patient. And if you compare that, there's 300 million Americans. Not all 300 million Americans are patients. Not everybody in America is actively receiving health care. I could say I never saw a doctor last year. Not with much pride, but I could say that. So I'm an example of a person who didn't cost anybody anything. But if you look at total U.S. healthcare expenditures, it's $2.3 trillion. And if you take the 30,000-foot approach there, it's $7,600 for every American was spent on healthcare. If you look at those, taking into account that the veterans are users of the healthcare system, and that's not true for all Americans, I would argue VA is probably a bargain in healthcare. Some strengths and challenges. Well, you heard me talk about the favorable quality statistics. And as a system, VA does have generally favorable quality statistics. Because of the computer system, we do have better management systems. I offer for debate how cost efficient we are. I think we are. We obviously have important niche enrollee characteristics. The nation's veterans deserve the care, the best care that we can provide them. I think it's important that there is a system that is well attuned to the needs of veterans. More and more, I can tell you a lot of healthcare organizations looking at the Affordable Care Act are eager to compete to get some healthcare dollars away from VA and are trying to learn our niche role. We don't do too much pediatrics and obstetrics. Now with more and more women coming into VA, we're going to start doing some more obstetrics and gynecological care. Right now I'm trying to partner with UCI and other non-VA organizations to provide that care. But when you start to see more and more, I think that obstetrics will come along. Pediatrics, I'm not so sure. And we try to have a customer service vision and to be sensitive to the veterans' perceptions of their healthcare. Just like all other healthcare systems in modern America, we survey the veterans about what they think of our care. And we do strive to improve those kinds of stats. So that's it for my formal presentation. So now, as I promised, I'm going to tell you about some other examples of what veterans are like. So you heard me talk to you about the one guy that lives in Temecula. Let me tell you about two relatively young veterans that I've seen in the last 3 to 4 years. These are both OEF, OIF veterans. So they're young guys, both are males. One guy is he's about 34 now. And he was in service. He saw combat for a brief period of time. He had one tour in Iraq. He is employed, has a wife and a kid, doesn't have any bad habits. He's not a smoker. He's not a drinker. He's steadily employed. His weight is creeping up. And that was my principal thing that I was trying to work with him on, is getting... A lot of you look like you're in your 20s. I was in my 20s once, and when you hit to be about 30, life changes a little bit. You can't just eat everything you want and never exercise. You have to start thinking about it when you get to about age 30. And he's at that level, and that's his principal healthcare challenge right now. He's well integrated. He doesn't have, certainly not overt PTSD. He doesn't carry that diagnosis. He shows up at work every day. He's a pretty happy, successful guy. So there's one example of a veteran. In contrast, I had a 26-year-old veteran. He's had a lot of challenges. First of all, he's built like a wrestler. Very powerful body, very physical guy. In high school, he probably was sort of on the bully side of the schoolyard population. Was in trouble from time to time during school. Didn't make it to college. When the option presented itself, he joined the service, and he confided to me he was excited about the concept of being in combat. And he liked being in combat. And he signed up and had, I think, 3 active duty tours in combat theaters. When he came back, he was very depressed over not having that in his life anymore. He had a young wife, and she was pregnant when he left for his first tour of duty. And the child was, I think, last time I remember, about 6 years old. He didn't have a whole lot of other skills besides combat skills. He was unhappy, frustrated, a lot of family issues, questions of spousal abuse were present. He had very scary looking, at least to me, tattoos, blood dripping from figures on his biceps. He's somebody that really struggled with a lot of, I think, mental health issues. He actually had, I saw him as an internist, he had a lot of physical complaints. He was sure that he had an endocrinologic illness because he said he had large swings in weight. And I can tell you I did a lot of extensive workup, sent him to an endocrinologist, tested every axis that that I know of and that the endocrinologist knew of, we really could not find any organic illness in him. And he was very angry about that. When I left the practice, he was still a very unhappy soul dealing with all of these problems, pretty much overwhelmed by family demands, not able to work steadily, really somebody who was very highly at risk. So there's another different face of a veteran. Let me shift gears a little bit and tell you about a veteran. I'll call her Ida. And I cared for her from the time she was probably about 62 to the time she was 82, when they made me be an executive and I had to give up my primary care practice, and I'm not happy with it. But anyway, she had been an Army nurse in her youth, and she was salt of the earth. After her Army service, she was a missionary. She had 2 grown sons, one of whom was developmentally disabled, and she cared for the whole time I knew her. She had hypertension, a little bit of overweight, some thyroid disease, and that's about it. But functionally, she was like anybody's grandma here. She could basically manage all of her activities of daily living, happy person, comfortable with her role in life. I think that her husband had died some years before, very dedicated to her challenged son. She didn't like antihypertensive medicines. She didn't like the side effects, and I always struggled with her to try and improve her compliance. And we sort of negotiated. I allowed her to run slightly higher blood pressures than I otherwise would have been happy with. But part of medicine is making deals with patients and being collaborative with them. And like I say, she made it to 82, and she was looking pretty good when I left the clinic. So I think she's doing pretty well. So there's another face of a veteran. I'll give you another one. The first veteran I ever met in a role of patient care at Long Beach VA was a guy, I'll call him Ed. And he was about 57 years old. He had been, I would say, kind of lower middle class guy, employed on and off, cigarette smoker, sometime drinker, worked in various types of manual labor, construction worker. First time I saw him, he had acute abdominal pain, and we wound up diagnosing cholecystitis. So he had gallbladder problems and had an uneventful hospitalization. He was one of my first hospitalized patients that I ever took care of. May have been the first H&P I ever wrote. And he had a successful outcome. We took out his gallbladder, and he did very well for about 5 years when he came back with a spot on his lung. And you remember I said he was a heavy smoker. Unfortunately, that spot turned out to be a lung cancer, and he died of that lung cancer within a year.
Can I ask a follow-up to that? So some of the people here are in public health prevention, and the smoking lung cancer relationship is what prompted this. And I wonder how much behavioral modification, prevention that you do when you see that when you ask.
We're trying to do a lot with that. First of all, that is one of the performance measures, is first of all, capturing the data that a person is a smoker. So it is a requirement that at every visit, when the nurse checks the patient in for a visit, in a routine appointment, she inquires, are you a smoker? And if the person is a smoker, she will offer counseling then. And then the provider, the electronic medical record, gives communication between the nurse and the provider. And the nurse will click the button saying smoker. The provider then is expected to close that, what do they call it? Close the reminder. It's clinical reminder is the term for these little messages. And so when the provider sees the patient, he sees that that button is clicked. He's expected, and he has to click a button saying, I counseled this veteran about smoking. And then there's a whole bunch of things. The other beauty of the electronic medical record, you can click a button and say referral to what we call the telequit program. That's one. We have several different options for that. One is we have in-person psychological, run by psychology group smoking cessation programs. For people who don't want to be in a group system, we can provide them the medications, the patch system. We do expect some motivation on the part of the veteran. They have to call a phone number and say, yes, I am interested in participating. And then we will mail them the medication and then communicate with them about their smoking use. Yes?
Sir, I have a question. How is it that doctors in the VA are dealing with the stigma management in the service for so many years about, reporting mental illnesses? I know that you're drawing a point here trying to say, the normal average veteran is not having someone who has PTSD and is schizophrenic or depressed. But you know that the military has always had this stigma that you cannot go to your CO or your NCO and say, I'm feeling depressed, I'm not feeling like going to the line right now. It's like you can, because then you're seen as a weak.
Yes.
So how is it that doctors in the VA are treating that? Because that is a big problem in the military.
I will agree with that. Now, not serving in active military duty myself, I have not experienced that firsthand, but I believe what you're saying. And I think that that is true. Now, you have to realize, from our perspective in the VA, we're usually seeing folks after they're out of the service. And so for us, it's not really considered as much of a stigma. And most of the veterans do not view it that way once they're out of service, because they don't have those pressures that you're talking about, because they're already out of service, so they don't have a commanding officer anymore. But you may be right. If they're identified as having a mental illness, what does that mean to their employer? Well, the number one thing we do, and boy, we're obsessive about this, is patient privacy. We're very careful about adhering to the HIPAA rules and not communicating anything about a veteran's health to their employer without the express direction from the veteran. So we do our best to protect the confidentiality of their health care. But I think, still, I can't really give a much better answer for that about what we're doing to combat the stigma of health care. Most veterans, I've seldom had a veteran shy away from a referral I've wanted to make. When it comes up that they have psychiatric issues, depression, and I suggest to them, have you thought that this might be due to a mental condition, that we have treatment for it? A lot of it depends on how you put it to the patient. If you're caring and you treat it so it's not stigmatized, you as the provider, I think that's the first step. And say, hey, look, and the science is on our side, right? There are lots and lots of research is saying depression is largely genetic, right? That's the modern vision of it. Schizophrenia is, there's some genetic component, but it's ultimately a biochemical disease. The more we're able to use those models and say it's not your bad behavior that you're having these challenges. It's not because you're a bad person. These are understood illnesses that result from processes that we are starting to understand better, and we have some tools to manage them. If you present it in that way, I think you'll get more cooperation. And like I said, in my own experience, it's not been, I can't really remember a time when I wanted to refer someone for mental health services that they refused it or resisted it.
So I like that you're showing that there's a diverse group of patients, and not everyone has PTSD or illnesses like that. But why is there the stigma, if there is a stigma, that a large population of veterans are homeless, or a large population of homeless people are veterans?
I think both of those things are true. I guess whether it's a stigma, first of all, I believe that's a demographic fact. It's certainly a fact that many of the nation's homeless are veterans. And so that is a fact. Why are they homeless? Well, a number of different reasons why they're homeless. And part of it has to do with onset of really serious medical illness. We heard about schizophrenia there. Certainly schizophrenia is overrepresented in the homeless population. Those are folks that when they're uncontrolled, their thinking is disorganized, they can't hold it together to get the resources to have a home often. Schizophrenia is an illness that has onset kind of around the time of people being in service. 14 to 28 or so is probably the prime time for developing schizophrenia. So you may have a lot of folks, and also often folks that maybe didn't do so well getting other kinds of jobs go into the service. And then during the time that they're in service, schizophrenia will manifest. Those are a lot of the folks that make up that population. And many of them have medical discharges because of the development of mental illness during that time. So I can't totally explain all the reasons why. And in general, this is something true about all healthcare. There's sort of two kinds of things about the facts of medicine. Theories about why things happen, they change as we get better and better understanding of pathophysiology and etiology of disease. I can tell you the half-life of medical knowledge is about 20 years, and that's about right. About half of everything I learned when I was in residency has since been found to be either not quite right or totally wrong. But observations about healthcare, those have been true since there was the first doctor. And it's an observation that veterans are disproportionately represented among the homeless.
How do you as a physician deal with a veteran who's in denial about their own condition? So like you said, the 26-year-old who thought he had an endocrine problem. How do you approach someone when you tell them, oh, you might have PTSD or schizophrenia, and they're in denial about it? They're like, no, I don't want to see someone. Like, do you as a physician just let it go and be like, all right, I'll discharge you, you can go home and live a low-quality life? Or do you keep like approaching them?
It's very tough. You do keep approaching them. I guess you're trying to win the war, and you let yourself lose a battle or two along the way. And so you don't want to, if the person, and this is not true, this is not unique to veterans. I think lots of people who have challenges, mental illness, don't want to face it, and don't want to hear that. And as you get more and more experience, you can almost feel it like an electric field when you're running up against that. My experience is when you get that, back off. Because if you're going to be oppositional, you're going to be viewed as the enemy, and you're not going to get very far with that person. And so what I find is, and the whole idea behind the VA platform of care that I described, the PACT, it's really longitudinal care. It's a partnership over time. And so you know that you're not building Rome in a day. And you say, okay, let's let it lie. Come back and I'll see you in 3 to 6 months. Let's see how you're doing that.
How about when their mental illnesses sometimes overlap with their physical illnesses, such as, say, you're schizophrenic or you have something else mentally, and then that interferes with your diabetes or your hypertension, so on. You maybe approach their support system and ask them to pressure them into looking into that? Or
Ooh, that's risky. That's hard to do. First of all, you can't talk about their health care to anybody else without their approval, number one. Sometimes you can get them to give you approval, though. And if you do, then yes, that can be a very powerful tool. Let me tell you another, you just reminded me of one of the saddest cases in my entire career. This guy, about 45, veteran, profoundly schizophrenic, and intermittently homeless, and sometimes in community-provided housing from one program or another. He had what started as a minor little sore on his jaw. It was a non-melanoma skin cancer. Skin cancer, the cancer doctors, they always talk about what great strides we're making with cancer, and more than half of cancer is curable now. Well, the half that's curable are basal cell cancers of the skin, which are not great cancers. They're very minor things that you snip them off, and if you snip them off early on, they're cured. Okay. To me, that's dishonest about the world of cancer. We can't really cure 50% of cancers right now. All right, this guy we should have been able to cure. His mental illness, he would not accept care for that. Now, I didn't see him in the early days of that. When I saw him, his entire jaw was engulfed by this mass. And he actually was admitted to the psychiatric side of the hospital, and I was called as a medical consultant to help. There was an infection related to this huge open sore that he had. And it was beyond, I don't think he lived very much longer than that. It was really beyond the point of treatment. And when I talked to him, I said, just to even talk to him about the problem, at first, I said, how long has this problem with your jaw been going on? And he said, what problem? And finally he said, oh, you mean the sore. And so there's an example of someone who is so profoundly disturbed, you almost could not discuss it with him.
In that case, can you maybe get a court order to say that this person is not mentally stable enough so that to make decisions that are...
You can, yeah. Then now you're getting into LPS, Lanterman-Petrus Short, which is the legislation that if somebody's a danger to themselves or to others, or gravely disabled, which you could say that somebody like that would be gravely disabled, we're in America. You're talking about depriving somebody of their civil rights and forcing treatment on them. We don't do that lightly. Sometimes.
So that was not an option for you?
I think that's why he got into the hospital at that point. But, should we have cut off that little sore when it was cut offable 10 years before? Ooh.
So that's to the discretion of the physician?
I think, yes, and not just the physician. It's physician and other people in healthcare who can influence him. And sometimes, his pharmacist could be a better influence. Sometimes a nurse could be a better influence. Sometimes, like you said, enlisting family. Other questions?
One thing I'm always hesitant when talking with the veteran is not forcefully inquiring about their service, but just even asking about it because I'm always hesitant about their future family members or whatnot. How do you ask about this?
Not only do we ask, we have to ask about it. It's on our standard form. First of all, part of it is some of it is just known because of that's once they come to when they get to you as a medical provider, healthcare provider. Usually they have first gone through the admissions, the screening process to see if they're eligible for care. And part of that is they have to bring their DD-214. A lot of these people speak fluent, governmentese. That's the discharge from service form. That's your ticket for health care. And right on there you can see what theater of combat they were in and so forth, what era they were in service. So that's usually known. I would say don't be afraid of that. The vast majority of veterans will love to talk to you about their time in service. The vast majority. There are some who will say, yes, that triggers flashbacks for me, I don't want. But usually, especially in the VA system, they're used to being asked that question. And then if they say, I don't want to talk about that, let it lie. Let it lie then. But you know what, if it's going to be a longitudinal relationship, when you see them later, over time, you gain their trust, you may find out what you wanted to know. Other questions? Yes, sir.
Doctor, it was about, you had mentioned that in the younger cohort of veterans from the more recent wars, you had more prevalence of mental illness and all of those other diseases. Now, what about when, World War II veterans were the younger cohort? Were they having that same...
That's a very insightful question. How has veteran illness changed across those cohorts? Well, first of all, probably they were a lot more like the current young veterans than we think they were. Part of it is we didn't have as good understanding. You know, in World War I, there was a condition called shell shock. Shell shock probably is PTSD. And so we didn't have that kind of language and understanding, and we didn't have a lot of the therapeutic tools. And we still don't have really adequate therapeutic tools, which are constantly being developed for those. So I think to some degree there was actually a lot of overlap, and those veterans when they were young had very similar challenges to the current young veterans that we see. I had a thought about that. Oh yeah, you guys know who Atul Gawande is? Atul Gawande is a great author. He's a Harvard neurosurgeon who likes to write. And he writes for New Yorker a lot and writes these fascinating stories. And he wrote something about what's different about this war as compared to prior wars. And it wasn't so much about mental illness, it was actually more about the physical injuries. Just the technology of war has changed. So, and actually he did a really interesting story going back to the Revolutionary, every war America's ever been in, the Revolutionary War. I think the ratio of death to injury in the Revolutionary War was like 88% or something, you know, like almost anybody injured, you pretty much died. Okay, and then there's been progressive, because of better technology, body armor, armored vehicles, other strategies for preventing injury. Now I think it's about 10% of people injured in service have a mortal outcome. What does that mean? That means there's a lot more disability and physical illness and challenge that we deal with now in modern VA medicine. That's one area where VA is really, I don't know if you guys saw in that, what a story, that guy who lost all his 4 limbs in service. This has been on MSN.com, it's on the internet lately. He got bilateral arm transplants. Anybody see that story? And I think they did some creative things with bone marrow to try and lessen the probability of rejection. VA is really doing a lot of exciting things with prosthetic limbs, and here's a transplant of tissue. So that's a whole thing that wouldn't have been an issue in Revolutionary War or even really that much in World War II. Interesting, technology has changed.
That reminded me, I was very impressed that the PTSD was defined with the VA population, and there's a lot that we learn in public health from the VA because the exposures are typically known, the population is well defined, but occasionally there are puzzles, and I remember, I think it was called chronic fatigue syndrome or something. If war had a population where we didn't know what was going on, chemical exposures we thought, but I don't know how much research VA actually does into these kinds of things so that we can learn.
I'll give you an example, and it's interesting. And you know what? It's a mixture of science and politics is about the best way I can put it. And to me, the best example of that is Agent Orange. You've heard of something called Agent Orange. Agent Orange is a chemical called dioxin that was used as a defoliant. Most people who were in the Vietnam conflict say if you were very much in the field of conflict, you probably got exposed to that defoliant. What disease is caused by Agent Orange? Well, there's actually very hard science that one disease in particular, a disfiguring skin condition called chloracne, is definitely caused by Agent Orange. If you ever want to see a very dramatic demonstration of that, Google, I think it's either Yevchenko or Yevtushenko. He was the president of the Ukraine, and he was poisoned in palace intrigue by dioxin. And there, you can find on the internet a photo, Google it under Google Images, and you can see a photograph of him before and after, and that's a very graphic illustration of the ravages of dioxin, ultimately a constituent of Agent Orange, causing disease. There is not scientific evidence to link too many other illnesses to Agent Orange. Nevertheless, the VA has labeled, I believe it's 9 conditions, including diabetes, lymphoma, prostate cancer, very common high prevalence diseases, at least prostate cancer and diabetes. VA has said, you know what, if you were in service and can show you were in a place where you were exposed to Agent Orange, and now you have those conditions, we'll say that you got it because of that.
Over the years, are the veterans living, or the life expectancy of veterans, is it increasing with the same as life expectancy of like non-veterans? And if it is, would you say the quality of life is it how well is it?
I think, to me, I don't actually have direct stats on that, but extrapolating from the original stats that I gave you, again, most veterans generally do well in American culture, and most of them don't have service-connected diseases, and they behave very much like the general population. My guess is that in general, they're about parallel. Now, I don't know if the life expectancy is increasing or decreasing in America today. I'm not sure about that. Anybody here know for sure? It's flat, yeah, and it's in danger.
Sorry, how does preventive medicine play a role in mental illness in veterans? So is there anything we can do prevent mental illness in veterans? Like, say, I'm not saying like prevent it completely, but I'm just saying like, while they're in service, is there any like mentoring we can give them?
Wow, that's a very sophisticated question, and it's really beyond my scope of true understanding. But I did have a lecture once by some military physicians, and they did talk about training that they have, something called battle mind. They talk about, and helping active duty servicemen understand the frame of mind they need to have when they're in a fighting situation, and the importance of relating that to how they have to be when they're not in that situation. What we do a lot more of is, they call it PDHRAs. It stands for Post-Deployment Health, Health, I forget what the R stands for, Health Reassessment, I think that is. And so what that is as veterans get out of service, we do early healthcare evaluations of them, looking to try and identify. So it's not very preventive, that's more like early recognition. They've already been in the service, this is again just when they're coming out of service. And we in the VA, we're partners with the discharging services. So we'll have these health fairs where we'll go to the bases, and as folks are being mustered out of service and basically turning into brand new veterans, we will invite them to apply for services with the VA. And part of that is a mental health screen to try and identify mental.
To me, I feel like maybe awareness that maybe serving the military may cause me PTSD or other mental illnesses, and I just maybe like take the precautionary measures. I don't know what they are, but if I'm serving the military, I'd be like, okay, like I know these things could happen, and I need to be prepared for them, rather than having it happen as a shock.
Yeah.
I feel like that would make you maybe ready.
I'm pretty sure they are, again, I'm not that familiar with the active duty resources, but I'm pretty sure they are doing that, and the VA part of it is, again, as early as we can in the career of a veteran, if you will, trying to assess for those kinds of things. Question?
Yeah, this is like more like a personal question, but when did you go into the VA healthcare?
My first clinical medical experience was in third year of medical school. When I went to medical school, you couldn't see a patient until you were in the third year at all. I know that now it's different than that, right? And my first experience was at a VA. And I just liked it. It was, first of all, the patients were very, like I said, very appreciative of the care, very comfortable. Then, what did I know? I didn't know anything. I was a third-year student. But they showed respect. It's like you're the doctor and you're the third-year student. And I felt good about it. And I wasn't bothered by some of the things that turn young people off to young health professions to the VA. And there are some things. VA, we're the government, so we're government employment. There are some things that are more inefficient in government organizations. And the VA has been like that. The Human Resources Department, for instance. VA is very careful about, you can't just fire people at will in VA. And some people think that sometimes we need to be a little bit more effective at separating people if they're not really on board. So there are some things that aren't as efficient, don't work as well. Those were things that really, first of all, I don't think they're an extreme issue. And I think those things exist to some degree in other forms of healthcare. And they didn't bother me. So first of all, the things that some people don't like about the VA were not things that bothered me at all. And I enjoyed working with the patients. And I also like, one great thing about the VA is that thing I talked about at the very beginning of my talk about the partnership with medical schools. There's a saying, the average VA doctor is smarter and lazier than the average non-VA doctor. I don't know if that's true, but we used to say that. You don't make as much money. VA is, we're government employees. You're usually not paid as much. Although, in my opinion, VA pays a fair wage now. And like I told you, for the psychiatrists, we had to, or they wouldn't come to work for us. But it's largely, it's not a 40-hour-a-week job. It's probably a 50 to 60-hour-a-week job. It's much more predictable. And it's in most of the VAs, certainly the ones that I went to, it's in that academic milieu where you work with medical schools, and that's why I stayed with it. I was vice chair of the Department of Medicine here, and got to collaborate with all the faculty, and that's a whole other area of professional fulfillment. And VA is a good place to make that happen. So for me, it was fine. I did my internship here, and I liked it. In 1979, I came here and put me in a corner somewhere and feed me, and I'll come back 30 years later, I'm still there. I only got 10 minutes, but yep.
Can you comment on how treatable PTSD is? We hear patients with PTSD, to get that diagnosis, does that mean that you have to be severely affected, and does that get better eventually, or keep it without?
There's a broad range of severity of PTSD. Some people are very mildly affected, others are profoundly affected. There is a lot of exciting new treatment. And this is a little bit not my area of specialty. I'm a medical doctor, internal medicine, but my psychiatry colleagues, they have something called EBM, EBP, evidence-based psychotherapy, which is, to me, that's kind of an outrageous term. because that suggests everything else we've been doing is completely, we made it up out of thin air. And maybe that's true, but evidence-based psychotherapy are some of these newer therapies. They have this, and some of them are kind of familiar old concepts. One of them is called, I think it's intensive exposure. And it's sort of like, it's like if you're afraid of snakes, it's making you be with snakes all the time. That kind of stuff. So it's basically in a controlled environment, having folks, with supervision, kind of face those things that are their demons, if you will. And I think actually there's very good data that shows that those are effective treatments and people function better. There's a whole range of these evidence-based psychotherapies. If you're interested in it, you should read about it, because I don't know that much about it. Yes?
A comment to reply to an earlier question about mental health and what you can do to maybe prevent or treat PTSD. I actually read an article recently. If you look up Marines mental fitness exercises, it's a new initiative that's starting in some parts of the Marines with experimenting with training, having the servicemen trained in meditation training. So supposedly it's leading so far in studies that have shown that Marines that do this sort of meditation training by the military are performing better, they're less stressed, they sleep better, they sort of take care of themselves a little more. And I think it's expanding, the Marines are expanding the use of that, and it may expand soon also to try and treat patients who have PTSD currently in order to, so that's one way I think one thing we're trying to do.
Great observation. And I bet as they're following cohorts, they will be able to demonstrate there's less incidence of PTSD later if people have been doing that earlier.
Yeah, that's a new thing. So if you Google that or something that interests you about ways that
Thank you very much.
Yeah.
We have time for any more? I think we're done, right? One more question?
So there are physicians who go to war. I guess they work for the Department of Defense.
Mm-hmm.
Do they typically come to the VA? I'm wondering how much of the VA physicians have the experience.
Not much. That's very interesting. Not much. For one thing, I think the physicians that are part of active duty, first of all, there's a lot of financial inducements to get folks to do that. And I think they have a very good kind of both compensation and retirement system. So they stay there, stay not that long, and retire comfortably. There is some overlap. One of my faculty members was a reservist, and after 9/11, she was called up. And so she was somebody who was a civilian VA doctor who became a military doctor for a couple of years and then returned back to us. But there isn't that much mixing. That's a good point. Interesting. One more question, that's it. Two more.
Can you see a relationship between veterans' health and the number of tumors they serve?
Good question. I don't know the answer to that question. And I can think of ways, like I said, beware when I explain things, because I probably, will be wrong later. Because sometimes I think people who reassign, who re-up, they cope well, they understand. They may be people who might have less mental illness later. But then maybe it's just being exposed over and over again can make them worse. I don't know the answer to your question. Very good question. And one last question, and then we're out.
In the veteran population, do you see an increased prevalence of musculoskeletal problems? And if so, how do you deal with that as they age?
We see there's kind of two different cohorts. The more elderly folks, they're all getting degenerative joint disease now. Just the arthritis that is common among older folks, needing hip replacements, that kind of stuff. So that's a very common musculoskeletal condition. For those, we're just the same as all other healthcare. We do a lot of orthopedic surgery. We do joint replacements, rehab programs. There's really not a distinction. I think it's the younger cohorts that are more interesting, where they don't really have that type of illness, but rather it's more some things where you really don't find so much. You can't define the organic disease. There's not an X-ray pathology that you find. It's more functional stuff, aches, pains. Actually, in some ways, that's closer to sports medicine. And there are some of the resources that are used in sports medicine are more helpful. Physical therapy, exercise programs, those kinds of things.
A follow-up question, do you see any stigmas related to the problems that they might face in terms of joints and ache pain or aching pain?
I don't see a stigma per se. What I keep remembering that guy who thought he had an endocrine disease. There's some folks who really their challenge is a PTSD-related mental illness, but they will focus on a physical symptom. Those are folks that are often very challenging to treat because you can't find anything objective. There's nothing on the X-ray, nothing on the MR. Often these folks will consume a lot of resources. Doc, there's something wrong with my knee. You do an MRI, which is the most advanced procedure we have. You can't find it. Now, true, medical technology has a threshold for detection, and it's not 100%. The sensitivity of our tests is not 100%. There's definite possibilities there's disease that we're not diagnosing. But I know that in my belief, a lot of physical symptoms may not be physical in origin. Okay. I don't have any more words. Thanks.
I have two announcements, so sit still. But first, why am I talking? Thank you very much for this presentation, and as a token of our appreciation, I'd like you to have this.
Thank you so much. Thank you.
A note about the evaluations. They are required, so even if you sign in, you have to be sure to fill out the survey, the evaluation. And also next week will be on religion and medicine. So thank you.
Please do fill those out. I actually read them last time, and I hope it helped. I hope you liked hearing about the veterans.
Thank you.
Thanks a lot.